Hello everybody. This is your second lecture on occlusion. It's on mandibular movements. You see the various actions of chewing, talking, swallowing, they're all brought about by different mandibular movements. And these mandibular movements, they occur as a result of interaction of four factors, which include the temporomandibular joints, the rotational axes of the mandible, your occlusal contacts, and the action of muscles. So, in this lecture, we will talk about the interaction of these factors to bring about the various mandibular movements. I hope you enjoy your lecture. Let's go ahead.
What I had explained just now has been put in this slide, that the mandibular movements bring about the actions of speech, chewing and swallowing, and they are brought about by the interaction of four factors, which are the temporomandibular joint, the occlusal contacts, action of muscles, and the rotational axes of the mandible. Coming to the anatomy of temporomandibular joint, it is a joint formed between the head of the condyle of the mandible and the glenoid fossa of the temporal bone. Coming to the details, this is the head of the condyle. Here at the neck of the condyle are attached the fibers of the lateral pterygoid muscle. This is the glenoid fossa of the temporal bone. Now the space between the condyle head and the glenoid fossa is known as the joint cavity. This joint cavity is divided into two parts by the articular disc. Here, the upper part is called superior joint cavity and the lower part is called the inferior joint cavity. Now TMJ chamber is divided into two compartments by the articular discs, the superior joint cavity and the inferior joint cavity. Rotation motion occurs in the inferior joint cavity and the translation motion occurs in the superior joint cavity. These motions of rotation and translation are performed either singly or in combination. Now what are these motions actually? That will come later on. Now TMJ can be described as a bilateral joint, which means it's on the right and the left side. It's a synovial joint. That means the joint cavity has synovial fluid. It is also known as gangliomo-arthroidal joint. Now the term ganglimus means hinge joint allowing motion in one plane, basically rotation motion. Now we see our mandible opens because of rotation that occurs in the temporomandibular joints. That is the ganglimus action. Then diarthrosis, it describes the change in position of the articulated parts by simple gliding motion. That is the translation motion, that means the head of the condyle, it translates or it moves forwards or downwards in the glenoid fossa. Thus, temporomandibular joint is a bilateral, synovial, gangliomo-arthroidal joint. Coming to the muscles involved in the mastication process. Now you know that mandible, like any other body part, it moves by the action of muscles, by their contraction and relaxation. Now these muscles which play a role in this are either directly or indirectly attached to the mandible. And the four pairs of muscles which are involved, they include the masseter, temporalis, medial pterygoid and the lateral pterygoid. Now we'll see a little bit about these muscles. The temporalis muscle, it is a fan-shaped muscle. You can see it here. It originates from the lateral surface of the skull and it gets inserted in the coronoid process and the anterior border of the ramus of the mandible. It can't be seen in this picture. Now the masseter muscle, here, it originates from the zygomatic arc, that is here, and it gets inserted in the angle of the mandible. Next are the medial and the lateral pterygoid muscles. As the name suggests, they arise from the pterygoid plates. Now pterygoid plate is an extension of the sphenoid bone. The sphenoid bone has two pterygoid plates, the medial plate and the lateral plate, and they're both present on either side of the head. Now this is the lateral pterygoid plate. Now the medial pterygoid muscle, it arises from the medial side of the lateral pterygoid plate. Whereas the lateral pterygoid muscle, it arises from the lateral side of the lateral pterygoid plate. So they're both arising from the pterygoid plate itself. Now where do they get inserted? The medial pterygoid muscle, it gets inserted on the inside of the ramus of the mandible. Here, the mandible has been cut. You can see on the medial surface of the angle of the mandible, it is getting inserted, whereas the lateral pterygoid muscle, it gets inserted in the neck of the condyle. You can see it here. Coming to the action of muscles. The jaw closing muscles, that means the ones which are lifting the mandible up, they are the masseter, temporalis, and the medial pterygoid. The jaw opening muscles, that means they are depressing the mandible. They are the lateral pterygoid and the anterior digastric. Now the protrusion and forward movement of the mandible is brought about by masseter and medial pterygoid. The retrusion and backward movement of the mandible is brought about by temporalis muscle. Now the lateral or side to side movement of the mandible is brought about by masseter, medial pterygoid and lateral pterygoid muscles. Now coming to the mandibular movements. Tell me something. Is it possible for you to pull your mandible down to your waist? Can you shift your mandible to the right or left to the maximum extent that you want? No. The movements of mandible are limited, and they are limited by certain structures. Now there are two types of limitations which there are. First is the posterior determinants. This includes the morphology of the temporomandibular joint. These are fixed factors. That means you're born with certain anatomy and that anatomy cannot be changed as per your desires. The second factor is the anterior determinants. Now this is the vertical and the horizontal overlap of the anterior teeth. This is a variable factor as we can influence that or change it to some extent by dental procedures. This is the temporomandibular joint area. The movement of the condyle hair will be influenced by the anatomical structures which include the shape of the articular eminence and the anatomy of the mandibular fossa. These are the posterior determinants. Coming to the anterior part. Now the vertical overlap of the teeth and the horizontal overlap of the teeth, they determine the extent of the mandibular opening. Now if the vertical overlap is high or more, that means the vertical jaw opening will be more. In case the horizontal overlap is more, then the side to side or horizontal movements of the jaw would be more. The mandibular movements are described with reference to three cranial planes: the horizontal axis, which passes through the heads of the condyles, the vertical axis, which passes through the head of the condyle and the posterior border of the ramus of the mandible, and the sagittal axis, which is an anterior-posterior axis. We will not be going in details with these reference planes. Instead, we will now come to the basic type of mandibular movements. There are two movements, the rotation and translation. Rotation is movement of a body around an axis. Now here the body is moving around this axis and the body is the head of the condyle. Translation is when all the points in a body have identical motion. It is something similar to pushing a toy on the floor. That toy translates on the floor or it glides against the floor. That is translation motion. The mandible rotates around an imaginary line passing through the centers of both the condyles. This imaginary line is known as the hinge axis. Now by virtue of this single movement, that means due to only the rotation of the condyle in the articular fossa, the mandible can open up to a maximum limit of 12 to 25 mm when it is measured from the incisal edges of the anterior teeth. This is called the terminal hinge movement. It is depicted in this diagram. You can see here the head of the condyle is rotating around this axis and the mandible opens from here till here. Now this is measured from the incisal edge of anterior to the incisal edge of upper and lower edges, and it is about 12 to 25 millimeter, and this type of opening is known as terminal hinge opening or movement. Coming to translation, it is the bodily movement of the head of the condyle in the articular fossa. Now this action, it occurs as a result of muscular contraction which produces a change in the relationship of the condyle to its articular disc within the articular fossa. So, under the influence of this motion alone, the mandibular forward thrusting or protrusion to a maximum limit of 10 mm can be achieved. Now let us see how it's happening. In this diagram, you can see that the head of the condyle is translating forwards from here till here. And you can see the mandible moving forward from here till here. This is protrusion, and it's occurring by the translation of the condyles. It is also well depicted in the photograph. Complex movement. These are the movements which are produced by the combination of rotation and translation motion. These complex movements, they allow a wide variety of actions like chewing, swallowing, and speech. Now you see, in our daily lives, it is the complex movements that are occurring. We hardly open our mouth slightly to a terminal hinge opening, or we hardly protrude our mandible forward, but we are talking most of the time. We're chewing, we're eating, or yawning, that is wide mouth opening. Up to a maximum limit of 50 mm can be seen when the condyles rotate and translate together. It is well depicted here. You can see that the condyle, head of the condyle is moving forwards and downwards. It is translating. At the same time, it is rotating around this axis. So when this is happening, the mandible is moving forward as well as it is opening. And here you can see wide mouth opening, which can be to the limit of 50 mm. Now we've opened the mandible less, protruded it, we've opened it wide. Let's come to the lateral movements. Now the lateral movements are described with respect to one side of the mandible, that is, for example, the right side. Now I want you to conduct an exercise. All of you, close your mouth. Now shift your mandible to the right side. The side to which your mandible has got shifted is called the working side, or the functional side, or laterotrusion. This is the side on which we chew, and this side is moving away from the midline. The condyle on this side shows rotation motion, and your opposite side condyle shows translation motion. The opposite side is known as the non-working side, balancing side, or mediotrusion. It moves towards the midline. So you followed? You can see clearly in this photograph, the mandible has moved away from the midline. Here, this is the working side. This happens to be the midline. This side has moved towards the midline. This is the non-working side. So I hope the concept of working side and non-working side is clear to you people. To make it easier, I have put it in form of a table. Now the working side, it moves away from the midline, we just saw. The condyles on the working side, they show rotation, and the Bennett shift is observed. But this we will do in the consequent slide. That's the next slide. Non-working side, this side moves towards the midline. The condyle shows translation motion, and Bennett angle is made with the median plane. Now let's come to the concept of Bennett shift and Bennett angle. Coming to Bennett shift. Now this is the working side. This side is moving away from the midline. The condyle on this side is rotating as seen here. Now sometimes, due to the looseness or the laxity of temporomandibular joint ligaments, the rotating condyle, it tends to show some lateral shifting as well. In this diagram, it is from W1 to W2. And this distance is very less. It's about 0 to 1.5 millimeter. Now this lateral movement of the rotating condyle is termed as the Bennett shift or the lateral shift, and this happens on the working side. Coming to Bennett angle, I want you to concentrate again on the diagram. This is the non-working side. It is moving towards the midline. The condyle is translating. This condyle is showing downward, forward and inward motion like this. Now this motion makes an angle with the median plane, and this angle is about 7 to 8 degree, and it is called as the Bennett angle. So the Bennett angle happens on the non-working side, whereas the Bennett shift happens on the working side. I hope this concept is clear to you. Now all the different types of mandibular movements that we've done, we can also group them into two types, functional and parafunctional. Functional are the normal movements, like I'm talking to you at this moment, it's a functional movement, chewing, speaking. Whereas parafunctional, they are the abnormal movements like bruxism, clenching. Now we'll define them. Functional movements of the mandible. These movements of the mandible take part inside the physiological limits established by the teeth, TMJ, and the muscles of mastication. These movements of mandible occur during chewing and talking. That means all the normal movements. Now parafunctional movements, these are the activities that serve no useful function and are mostly harmful to the dentition and associated structures. They can cause tooth mobilities, wear, TMJ pain, headaches, etc. And the examples are bruxism and clenching. So they are parafunctional activities. So you should have an idea about these. Now, a very interesting concept, a concept of mutually protected and group function occlusion. You see, people did a lot of studies on teeth arrangements, and they observed that some mouths were such that the periodontiums were healthy, the tooth wear was minimum, and the intercuspations were in centric relation. Now, these teeth arrangements were the ones in which there was minimum damage to the dentition and they lasted for a long time. So such teeth arrangements led to the development of concept of mutually protected and group function occlusion. Mutually protected, canine guided or organic occlusion, they all mean the same thing. Now I want you to conduct an exercise. All of you close your mouth. Shift your mandible to one side, say the right side, in such a way that your upper and your lower canines, they are in edge-to-edge contact on the right side. Now observe your mouth. In case all your anterior and your posterior teeth are disoccluded, then you possess canine protected occlusion in your mouth. In case it's not so, then you may be possessing another type of occlusion. Now what I explained just now is well portrayed in this photograph. See, the mandible was shifted to this side. The upper and the lower canines, they are in edge-to-edge contact, and in this condition, all the anterior teeth and all the posterior teeth of both the sides are disoccluded. Such a occlusion is called canine protected occlusion. In this diagram, you can see edge-to-edge contact of the canines and the posteriors on that side are all disoccluded. And this happens on the working side. Now, according to this concept, the anterior teeth, they bear the load and the posterior teeth get disoccluded in all the excursive movements of the mandible. This explains the minimum tooth wear. Now, during maximum intercuspation, the condyles are optimally or comfortably positioned in their fossa. Therefore, there are minimum stresses in the system. Now, when the posterior teeth, they contact, the occlusal forces are directed along the long axis of the teeth. So, minimum tooth damage happening. The anterior teeth, they either contact lightly or are out of contact. Therefore, no obliquely directed forces act on them, which would have occurred if they were in contact. So since all these good things are happening, therefore the dentitions in this concept, in this arrangement of teeth, they get preserved for a long time. Another type of occlusion is the group function occlusion. It is also known as the unilateral balanced occlusion. Now I want you to conduct the same exercise again. Close your mouth, shift your mandible to one side, say the right side, bring your upper and the lower canines in edge-to-edge contact and observe in your mouth. What do you see? In case on the working side, that is the side to which you shifted your mandible, all the teeth are in contact, and on the opposing side, the non-working side, the teeth are disoccluded, then you are possessing group function occlusion in your mouth. In this type of occlusion, on the working side, the teeth they function in a group and distribute the occlusal load. This is the best alternative to mutually protected occlusion. You can see it in the photograph here. The mandible has been shifted to one side to bring the upper and the lower canines in edge-to-edge contact. The first premolar, second premolar, and the mucobuccal cusp of the first molar, they form a group and they distribute the occlusal load. Now on the opposing side, the teeth are disoccluded. If we come to the diagram, you can see it here. The canines are in edge-to-edge contact. The first premolar and the second premolar, mucobuccal cusp of the first molar, they all function in a group. That is all in this particular lecture. All the data has been taken from Textbook of Operative Dentistry by Sumita Sandhu from the chapter of occlusion. If you want to have a more deeper insight in this chapter, you can always read it from there. I hope you liked this lecture. If you did, do like it, comment on it, share and subscribe to this channel. In case you have any doubts, you can please put it in the comments section and I will try and solve your problem. Thank you so much. That's all for this lecture.